You're watching Cetome TV. Knowledge is power.
So what do you think is most important for people to know about triple negative breast cancers, or how do you want to talk about this?
There's many different types of triple negative breast cancers.
Oh, okay.
Yeah. So,
and when you say types, what
we call subtypes.
Okay.
All based on different genetics. Many years ago, we have these massive databases of DNA. Massive databases, and many scientists, they just go through these databases and they say, well, let's take 10,000 of these triple negative breast cancer patients and let's sequence them all and compare that DNA and compare it to our patients and compare it to treatments, and let's just play with this data and see what it looks like. And so the outcome of that was what was called the consensus subtypes of triple negative breast cancer. Okay. And so originally it started out with 6. Brilliant scientist named Lehman was the one that basically came up with this, and it's called the consensus subtypes. And he came up with 6 different subtypes. The first one was called basal-like immune, and then there was immune modulary, and then there was LAR, and then mesenchymal, and then mesenchymal stem cell-like. And
that's 5.
So 6.
Oh, was that 6?
Yeah.
Okay,
Immune. There's immune.
Okay.
So basal.
No, don't worry. I'm sure we've
got
it.
We're going to go over them. It's been modified since then.
Okay.
So this is quite a while ago.
Now, can I just clarify, is this all breast cancers, or is this triple negative?
That's an excellent question, and we'll get to that, but this is specifically triple negative.
Okay,
yes.
Thank you.
Yes.
Okay. All right. What do you want us to know about these 6 types?
So they all had different genetic expression. They all had different mutations that were common to that subtype. And this opened it up because oncologists were treating all triple negative breast cancers, and they still do to a certain degree, with the same tools, the same drugs. And some patients, they would work really well. Platinum drugs would be great, and then other patients they get nothing from. And so by looking at these different subtypes, we saw that they're caused by different mutations and different genetic expressions. And lo and behold, for many of these subtypes, we have drugs that target them. We just need to borrow them from different types.
This goes back to what I was saying earlier about how cancer used to be diagnosed by location, and now that we have this genetic testing ability, it's by mutation.
Right.
And so what you're saying is they didn't have to design necessarily new treatments once they identified these types. There were treatments for those mutations.
Yeah, exactly.
Oh, wow.
So I personally believe there's probably going to be about at least 40 to 50 different subtypes of triple negative. They all fall within, I would say, 4 or 5 main classifications. And each one of these 4 classifications can have many different subtleties, different variations within those subtypes.
Now, is there the same type of diversity in the other 2 most prevalent types?
Not as much, but there is definitely, and that's something I was going to touch on, but I don't want to touch on it quite yet.
Understood.
So the first one that is well established now that we look at is called the basal-like, and they resemble basal skin cancers, and the new designation for them is basal-like immune activated, and that's the first class. And they typically have BRCA1 mutations, whereas commonly, mutations in BRCA2 happen in estrogen-positive breast cancers. These usually have BRCA1 mutations. And because of that, they can be treated with a class of drugs called PARP inhibitors. And sometimes immunotherapy, but more importantly, they respond very well to platinum-based drugs like cisplatin, carboplatin. And
are those PARP inhibitors?
No,
that's a different thing.
Yeah, these are platinum
Remember,
drugs.
we don't know this.
PARP inhibitors and platinum drugs work in a similar way, but PARP inhibitor is a targeted therapy, and platinums are chemotherapy.
Okay.
So the second class is called the basal-like, but they're immune suppressed. So in other words, they don't have, so in the first type, basal-like, they are immune activated. And so they have T cells and immune cells inside the tumor that are trying to actively fight it, but have been shut down typically by some sort of mechanism, one of the different mechanisms that inhibit the immune system. So the second class is basal-like immune suppressed. And so they don't have these immune cells. So they have the same sort of genetic features, not entirely, but they don't necessarily have that amazing response to platinum drugs, and they don't have that response to PARP inhibitors
because
as well.
those immune system bits aren't in the cell as well.
Exactly. Yeah. Now, these basically have the worst survival. The basal-like immune suppressor called BLIS, B-L-I-S, and the basal-like are called B-L-I-A, BLIA. So those are the first two classes. They happen much more commonly in Hispanics, and they're less frequent in Asian populations.
Both of those, the BLIA and the
no,
BLIS?
Just the BLIS.
Okay.
Yeah. And so the BLIS is really the worst one to have. But, you know, if you have certain mutations in there that can be targeted, you know, you could get a good response. But typically they have the worst survival with standard treatments.
That's the hang on, don't get too worried because, okay, good.
Everything's based on standard treatments.
Right, which we can go well beyond.
Yes,
right.
yes.
Okay.
So the third type is called luminal androgen receptor. And so these typically happen in older patients. They have the best survival. They're very common in Asian people. And they are based on mutations in genes like PIK3CA, which we have some great targeted drugs now for. And more importantly, they express the androgen receptor. And as you know, we have two different receptors in males and females. We have the estrogen receptor for females, and we have the androgen receptor for males. And so overexpression of the androgen receptor causes prostate cancers, and overexpression of the estrogen receptor causes estrogen-positive breast cancers. So this class, the third class, LAR as it's called, actually has expression of the androgen receptor. And you can treat these patients with prostate cancer drugs. And it's you know,
so a breast cancer patient, a woman,
is a woman with breast
although
cancer.
men can get breast cancer.
Yes. You treat these patients with prostate cancer drugs. Yeah.
Right. So further to the point that location is not a determinant of what cancer treatment is going to work for you.
It's genetics of it. So we've actually recommended treatments for patients. They've responded incredibly well on standard prostate cancer drugs. I remember, you know, the shock on the doctor's face. He says, you know, bloody hell, what, you want me to give her a prostate cancer drug? Here's the data.
Right.
So, and the patient responded incredibly well.
Right.
And then the final type is called mesenchymal. And mesenchymal is a type of cell. It's a bit of a transition cell. And it's probably the most common, and it occurs in younger patients. And typically, triple negative breast cancers typically occur more commonly in African American patients and Hispanics, and they're typically diagnosed under the age of 40. And so I believe that there's, you know, when I see triple negative, I pretty well always assume that there's going to be
an
inherited genetic feature.
Right, which we can test for and prove that you do or don't have, which then gives you all the evidence you need to get these targeted therapies.
Yes. So in mesenchymal, there's many different molecular markers. We had a woman that was slightly mesenchymal. She was on death's door, and we found she had an FGFR mutation, and these are common in these patients. So we got her on an FGFR inhibitor, and she got 2 years of cancer-free life out of that. They also have what's called MET amplifications, and so you can use MET inhibitors too. And then they have mTOR mutations too. And mTOR inhibitors are drugs that inhibit certain pathways like PTEN and PI3K signaling.
Those are common cancer pathways.
They're
Anti-cancer pathways.
actually, there's a drug called everolimus, which is approved. It's been around for quite a while. It's a targeted therapy. It's approved for estrogen-positive breast cancers. And in these mesenchymal types with overactivation of this mTOR signaling pathway, this drug is very effective. So there's an indication where, you know, it's not approved for triple negative. It's approved for estrogen positive. But it's very effective in these triple negative patients too.
And why is that?
It's just the pathway that is activated in it.
Right. So that the drug for the other type, the estrogen positive, was designed to influence that pathway.
Yes, exactly.
And in this triple negative approach, the mesenchymal, that's a similar pathway.
Exactly.
Yes.
I
see.
Yes.
Mm.
So there's many options for mesenchymal. We've seen a lot of different genetic changes in mesenchymals. We've seen all kinds. I mean, we've seen BRAF mutations in mesenchymal patients, and those are common, and those are for melanoma. So you can use BRAF inhibitors. And then there's what we've discovered on top of these 4 general basic classifications is there's also what we call equivocal versions of estrogen positive and HER2 positive breast cancers. So in other words, they don't have enough expression to say without a doubt that they are ER positive or PR positive. They're only slightly positive, but they're classified as triple negative. But these patients can respond to ER inhibitors and the standard treatment for ER positive or HER2 positive breast cancers. You need to add different combinations of drugs, and they're not going to respond as well as the classic ER positive or HER2 positive. But even that slight expression dictates that. And the other thing to remember too is expression of these receptors like HER2 and ER and PR changes in response to treatment. So, I mean, HER2 is one of the biggest ones. So the amount of HER2 expression you see on the outside of a cell is based on typically is based on how often this gene is expressed, but also how many copies of the gene you have. And so we've seen an increase in copy numbers of this gene, not only between individual cells in the same tumor, but also across different tumors. So a patient will come to us and they'll say, well, I'm HER2 negative. And it just so happens that that biopsy just hit an area of the tumor that was HER2 negative. When we do our liquid biopsy and we test the entire body, we'll see, maybe 20 copies of the HER2 gene. It just wasn't in that area where the physical biopsy was.
Which is why the tumor tissue testing itself is really not conclusive.
Yes, no, you need both.
The liquid, the blood-based test.
Blood-based testing along. I'm definitely for the receptors. Definitely for MET or for HER2. Definitely, you want to do a blood-based test. It's much more accurate.
And then it opens up all sorts of treatment options. That's the reason why we're talking about this stuff, is not just so you know a little bit about the back end of what creates cancers, but because there are treatments.
Yeah, there's some great HER2 targeted therapies.
So knowing for sure that you do or don't have that status can really make a huge difference to how your treatment goes and the ultimate outcome.
Thank you for watching Ketome TV. Subscribe below and stay informed.